In this lecture, we're going to talk about the general approach to a patient, a way of kind of organizing your thoughts. And when you get to a patient and you can be kind of overwhelmed and your heart rate's going, your adrenaline's pumping, how do you kind of settle your mind down and take your own pulse first and really try to think about, okay, what's the priorities as far as keeping yourself and the patient and everyone safe? How do you collect your thoughts? How do you prioritize what interventions you're going to do for the patient? How do you do an examination and concept, and then how do you translate that information to other people and share that information? So let's do this in the context of a scenario. Generally, I think of everything kind of better in the context of a scenario, and it will kind of help highlight some of these points. So you have an alpine climber, and he injures his lower leg after falling up on Mount Rainier, and he spends the night out unprepared, and he has some medical problems, a history of diabetes and high blood pressure. And as you're getting ready for this mission and you're head up the trail, how do you prioritize your approach? What's most important? And then what is it that we actually care about? So this is something that you can find online. It's borrowed. The National Outdoor Leadership School kind of coined and developed this, but this is also very similar to what the emergency medical technician basic approach is, as well as the National Ski Patrol's outdoor emergency care. And you can use this, you can use a myriad of other things, and really where I think this adds some value is not so much as an absolute must do it this way every single time to the T. This is by no means the only way of doing this, or not even necessarily the best way of doing this, but I think it does a good job especially for visual learners. And if you can memorize this and write this down and have this at least in your mind as a visual roadmap of how to approach a patient, the value that will serve is that when you're nervous or anxious or tired, it'll give you a place to start, and it will make sure you at least have kind of a trail to follow to get from beginning to end. So with that being said, the scene size up, this is kind of where we begin. And what this means is as you're approaching, start to take in the bigger picture of the context of the environment that you're doing the rescue. The most important thing you can do is think about what are the hazards, what are the risks. Are you at risk at rockfall? Are you in a river? Are you in avalanche terrain? Where are you and your fellow rescuers and the patients and the other bystanders gonna get hurt, get into danger, and what is it that you can do to mitigate those circumstances? One of the most important things you can do is take note of the MOI, or the mechanism of injury. Almost everything can be told in the story of what had happened to the patient, especially in the outdoor environment. A lot of what we're dealing with is trauma, and the things that you need to be worried about can be told in the story of what's happening. So it's important that before you kind of wrap up this encounter and get ready to communicate it, you should have a very clear picture in your head of what happened, whether it's a medical issue or a traumatic issue. And BSI, body substance isolation. So before we kind of dive into taking care of a patient, are you protecting yourself from blood? Are you wearing gloves? Are you protecting your eyes? Do you have a plan in place for dealing with contaminated materials? Then the next major part is dealing with the things that are going to kill your patient first. So we really need to focus on the life threats. Now, there's been some recent change in the American Heart Association and American College of Cardiology approach to basic life support in terms of changing the classic paradigm of ABC, airway, breathing, and circulation, to CAB, starting with circulation, airway, and breathing. And I think that that's an important concept for an unconscious, unresponsive patient that you're initiating CPR on. And I think that it's less important the order in which you do these, and more important that you focus on these things first. In the approach to the trauma patient, we still think about this in the context of stabilizing airway, breathing, and circulation first. And I think that's a perfectly fine approach, especially for the backcountry environment where these people aren't necessarily falling down in a cardiac arrest immediately in front of you, but these are more so potentially sick and unstable patients that we're coming upon with a little bit of time to think and prepare. So with airway, really focusing on, is their airway patent? Is it open? Is there anything in there that can cause problems? Are they breathing adequately? What's the integrity of their chest? For circulation, not only is it, do they have a pulse, do they have any bleeding? And then it's decisions on disability. And with disability, really what we mean is neurologic injury or compromise. And then E for exposure, making sure that we look at every inch of skin, that we're identifying all major and significant injuries, and that we're not missing anything. And then the next part of this triangle is a combination of a history and physical exam and vital signs. And the order in which you do these is more so going to be dictated by what's going on. If you have a patient that just slid down an embankment and is now having multiple injuries, getting some vital signs and doing a head-to-toe exam and really understanding the extent of those injuries is probably the most important priority. That being said, if you have a patient that's presenting with more of a medical problem, getting a good understanding of what's going on and the symptoms they're having and their other medical problems is probably more important than starting with your head-to-toe exam. So, you want to do your history and your exam and get your vital signs in this phase. And a lot of people will learn how to do an exam and their history at the same time. And if you have other people assisting you, if you're more than just one medical person, a lot of times you can get your vital signs at the same time that somebody else is doing an exam and a history. So these don't have to be done in sequence. And there's certainly no one right way or one perfect way of doing it. But the general concept is, stabilize the life threats and get the most important information first, so you really have a quick understanding of how sick this patient is, what the predominant injuries or illnesses are, and what you need to do. Then you want to literally formulate this in a problem list. You want to have an exact understanding of what's going on with your patient, and you want to develop a plan for it. This is not the same thing as a diagnosis and a treatment plan. These do not have to be exact things. So rather than saying this person is having a heart attack and a myocardial infarction, it's okay to say this person's having chest pain, because you might not know what's going on. They might just be confused. They might have abdominal pain. They might have breathing problems. So this is not necessarily a diagnosis. It's a list of what's going on with our patient, so we can start to formulate a way of thinking about it. And the next is interventions and treatment. So what is it that we're going to do to this person? How are we going to stabilize them? How are we going to make them more comfortable? How quickly they need to be evacuated? What are the means of evacuation? What additional help or resources do we need? And then long-term monitoring. So again, this is not the one and only way to approach this, but it's certainly a way that if you do this and you follow this, you're going to get the information, and it's going to force you to go through the steps to make a good plan. So let's look at this in a little bit more detail and go through these steps in a little bit more phase. So again, the scene size up happens the second you get the page. So this is not something that necessarily happens only when you get to the patient. And certainly before you leave the vehicles and before you head on that trailer or you head into that helicopter, you should really collect as much information as you can about what environment are they in. Look at topographical maps, understand what the weather is, understand the number of patients. You might have more than one patient. What's the mechanism of injury? What's the location in the terrain? And this is going to dictate a lot of the medical equipment that you might need to bring with you. So based on the mechanism, based on the medical history, will help dictate what equipment you need to bring with you. And then what protective equipment are you going to need for not only you, but for the patient? Life threats. So the most important thing we can do is really focus on the things that are going to kill our patient first. So we certainly want to control massive bleeding. Massive bleeding in a patient who's been breathing well enough to wait for you to get to them. Massive bleeding is probably going to be one of the first life threats that we encounter. And we can control this with direct pressure, with hemostatic gauze. Simple dressings can be simple as direct pressure with one finger or one hand, or it can be as complicated as the application of a tourniquet or special splinting. Then we want to make sure that our airway is nice and open. This is more than just are they speaking. This is more than just is their mouth clear. It's do they have any dentures? Do they have any broken teeth? Do they have any bleeding going on in their nose or in their mouth that can cause an airway problem? If they have any gum or food in there, take it out. Are they likely to vomit, and have they been vomiting, and is that going to cause an airway injury? We want to make sure that we're protecting them from hazards. So if we're in avalanche terrain and they don't already have one, put a beacon on them, protect them from rockfall. Do we need to do a very quick stabilization and then rapidly transport them to an area where it's safer to do a more detailed assessment that may be perfectly appropriate. A great example of that would be on a cliff where you're doing a helicopter pickoff, or when you're in a river doing a swiftwater rescue. You're not going to do a complete assessment until you get them to a safer environment. Consider spinal injuries. So this is the time where we need to think, what are their complaints? Are they having neck or back pain? Do they have any focal neurologic abnormalities? And what was the mechanism of injury? And are we concerned about a spinal injury? Because if we are, that's going to change the way that we move our patient, and it's going to change the way that we assess our patient to protect them. And then check our airway, breathing, and circulation. And that's not only just, is the airway patent? Is it nice and open? Are they breathing? Do they have trauma to their chest? Are they taking nice, full, deep breaths? Are they having wheezing? Are they hypoxic? Do they need supplemental oxygen? And then for circulation, it's, do they have a pulse? What's the quality of that pulse? What are their blood pressures? Are they bleeding from anywhere? Do they have blood loss? Have they been dehydrated and not drinking fluids because of altitude illness for a couple of days? And are they dehydrated? Do they have IV access by the time that we get there? And if not, is it something that they need? If it's something they might need, we don't have the equipment or the capabilities of doing that. How do we get those resources mobilized? And assess for significant neurologic injuries. So what do their pupils look like? Are they equal? Do they react? Do they know where they are, what their name is, how they got there, what the date and the season is, their birth date? Are they moving their hands? Are they moving their legs? Do they have any obvious weakness or sensory problems anywhere? And then expose the body from head to toe. Now, if it's cold outside or there's rain or snow, we might need to do this one phase at a time, but we can't get lazy, and it really is important, even if they're significantly clothed, to make sure, especially if they're confused, altered, or unconscious, or if they've had a significant injury and they might not be aware of all the injuries that they have. It's important that we look at them from head to toe, or we might miss things. With the head to toe examination, this is something that's easy to practice on each other. And really what we're doing is we're looking for any abnormality. We want to go to the skin, especially in patients that are confused or altered, or may have been an adrenaline rush and might not be aware of what's going on. And we're literally going to start from the head and work our way down to the toes, making sure that we also get the arms. There are many ways of doing this. There is certainly no one right way or perfect way. The important thing is to not get distracted by obvious injuries and focus all of our attention on there until we make sure that we've really assessed them everywhere else to make sure we haven't missed anything. Touch every bone. That includes the face and the teeth and all the bones of the hands and the feet. Make sure that we move every joint. Look for swelling. Look for pain. Look for the crunchy movements that broken bones make on each other called crepitus. And really look in every spot. This picture is an example of a lightning injury or a ferning pattern. And somebody who's complaining of a headache or chest pain, or may have passed out or lost consciousness and not been aware of what's going on. We may miss the underlying reason for the patient's injury or illness if we don't look at them in its entirety and make sure we get all this information. Vital signs. Vital signs can be pretty simple, and vital signs can be complicated, and the extent of the vital signs that you do are going to depend upon how sick the patient is, what your skills are as a medical provider, and what equipment you have available to you. We're going to talk about these things kind of in the context of what the traditional medical vital signs are, but I can't overstate the importance of still checking vital signs even if you don't have specialized equipment and what the implications of that are. So for mental status, the easiest way to describe mental status is, are they alert? Are they awake and conscious and oriented and talking to you and understanding what's going on? Or are they not really responsive and they're only responding to verbal stimuli? Are they not saying anything as you approach until you talk to them and ask them questions? Or are they not responding to you verbally at all and only move or groan if you cause a painful stimuli, poke a wound, or cause pressure to their nail beds? Or, despite the painful stimuli, are they completely unresponsive? One easy way of remembering this is the mnemonic AVPU, AVP, alert, verbal, painful, or unresponsive. If you forget this, it is perfectly fine to just say, okay, I know it's important to describe their mental status, and just do the best you can in plain language, and that's perfectly fine. It still paints a good picture. An example is, well, when I come up to the person, they're not saying anything, and they have an obviously deformed leg, and when we tried to move it to splint it, they moaned a little bit, but they still didn't tell us what their name was. I mean, that would be an example of responding to pain or painful stimuli only. Their heart rate. We can check this with a radial pulse. We can also check it with a carotid or ephemeral pulse. And what we want to do is measure it for 30 seconds and multiply it by 2. A good general rule of thumb is if it's less than 50 or if it's greater than 100, then that's concerning for multiple reasons. In general, a patient that's in pain is going to have a faster heart rate, or if they've had blood loss or they're dehydrated, they're also going to have a faster heart rate. A patient with a lower heart rate could be an indication of a head injury or internal hemorrhage or bleeding, could also be a side effect of medications. For respiratory rate, the quality of their breathing and how they just look to you as a human being when they're breathing is going to tell a lot of the picture. Even if you don't do a full job of measuring their respirations or checking their oxygen saturation, if you look at the person and say, well, they've been sitting here resting for several hours and they're still panting and trying to catch their breath, and it looks like they're working to breathe, that tells a medical provider almost everything they need to do in regards to the respiratory rate. But if you can, count it for 30 seconds and multiply it by 2. Also talk about what's their body positioning. Do they look like they're struggling to breathe, or are they working harder than normal? Blood pressure. If you have a blood pressure cuff, monitoring blood pressure can be very helpful. If you don't know how to do this, ask a medical provider with your team. And most teams will have the equipment available to do this. There are ways of checking blood pressures in different locations to see whether or not they have blood pressures in places where the blood pressure is higher and lost it where it's lower, to try to approximate blood pressure. When we study this, it turns out to not be a very accurate approximation, but if you check it in the radial pulse and there isn't a pulse, and you check it in the carotid pulse and they do have it, that does tell you that their blood pressure is probably not strong enough to perfuse out to their extremities, but they are perfusing locally, and that does provide good information. Capillary refill, especially in kids, can be a good indicator of circulation, and the way that we check this is by squeezing the fingernail bed and watching the pink go away as we push the blood out of the nail bed. And as we release the nail bed and we watch that pink color come back, the amount of time it takes for that to happen is the capillary refill. A normal, healthy perfusion will be generally less than 2 seconds. If they're hypothermic or cold and they've shunted the blood away from their periphery, that could easily take longer. However, if somebody is in shock and has a low blood pressure or they're not perfusing well, a long capillary refill time, especially in a patient who's warm in the summer months or spring months, is an indicator of poor perfusion. And their skin, the quality of their skin, the color. Is it warm? Is it hot? Is it cool? Are they dry? Are they sweaty? This is really helpful because the skin is one of the largest organs in the body and is one of the first to show signs of shock as well as dehydration and hypothermia. So the history, an easy mnemonic for remembering what are the fundamental elements of the medical history is sample, or the sample history. And again, it's less important that you hit on every single one of these as much as it is understanding what's the information we're getting and why it's important. So the most important thing to be able to do is to be able to tell the story, repeat the story, understand things. How did things begin? Where did the problems happen? What happened to the patient? How are they feeling? What is their history? And being able to turn around and to describe that. And if you can't turn around and tell somebody else the story about what happened to the patient, then you haven't asked enough questions. And you'll miss information and maybe have a misunderstanding of what's going on. What do you see? What are the symptoms that they have? How do they feel? It's important to know their allergies. If you're not a medical provider, but you have one in your team, or by the time they get to their hospital, they'll likely be getting medications for pain or nausea or potentially even infection, and it's important to know right away. Even if you don't plan on administering a medication yourself, your patient may decline and decompensate and lose consciousness, and you might not have the opportunity to get a history down the road. So if you can get a history while your patient is awake and alert, that information can help other medical providers down the road. So what are their allergies? Current medications, past medical history and surgical history. And for last meal, the last meal was more relevant when, under emergency circumstances, we were worried about doing anesthesia for patients with a full stomach for the concern that they would throw up while they were sedated and or paralyzed and end up aspirating all that contents into their airway. And for that context, we don't really care anymore because we're finding out this is less and less of an issue, and it's certainly not going to change the way that we manage these patients. So instead, where I think that this is important is having an understanding of has your patient been drinking and keeping themselves hydrated? How much sugar do they have in their system? How much nutrition do they have in their system? Because for the vast majority of these patients, we're going to want to hydrate them and give them energy to keep them shivering and to keep them warm and to keep them strong enough to try to assist in their own rescue as much as possible. And events leading to the accident, what actually happened? So with the history in general, that to break it down even simpler than the sample mnemonic is, what is the story? What is the narrative that happened to them? What are their other medical issues? And what are the things that are relevant to their health history that we need to know going forward? So the focus spine assessment. So early in the encounter with this patient, we need to identify, did they have a mechanism of injury? Do they have signs or symptoms or injuries that make us concerned about a potential spinal injury? This is especially important in patients that are unconscious or that are altered and confused and are not going to do a good job of managing their own spinal alignment. And this is less worrisome for us in directing the patient. Patients with spine injuries that are awake and alert are unlikely to cause worsening injuries to themselves. People have generally pretty good protective mechanisms. It is more important for us to make sure that we're not doing anything externally to the patient that could cause and or exacerbate an underlying spinal injury. So do they have midline pain in their neck? And this is going to be significant pain. We're less worried about mild pain on the side of the neck, especially with like skiing injuries or falling injuries. Do they have pain in the middle of their back along their spine? Do they have a focal neurologic deficit? And what that means is, do they have weakness in just one part of their body? Are they having lack of sensation in one part of their body? Are they alert? Are they awake? Do they understand what's going on? Can they talk to you and tell you what's bothering them? Do they have any intoxicants on board, any drugs or alcohol? And then do they have any other significant injury that is so severe that if they had a severe neck or back pain that they would be distracted and unable to identify? And this would have to be a pretty significant injury, major head trauma, major extremity trauma, a femur fracture. This would not be a sprained ankle or a cut. If they have absolutely none of these things, no neck pain, no back pain, not a significant mechanism of injury, totally intact, symmetrical, and normal strength and sensation in their arms and legs, they're awake and alert, they're not intoxicated, they're fully coherent, and they have no other distracting injuries. If that patient has none of those things, then it's okay to move on to a next level of assessment. And if they have normal range of motion in their neck and no significant pain and they're able to move it from side to side at least 45 degrees, then you are more likely to cause harm to this patient than benefit by putting them in cervical spinal immobilization. So for patients that meet this criteria, it is perfectly appropriate to comfort and pad them using a vacuum air mattress or traditional litter padding materials and not put them on a backboard and not put them in cervical spinal immobilization with a C-collar. We're finding that we're causing significant injury and significant harm with long spine boards for prolonged periods of time. And the usefulness and efficacy of rigid cervical collars is much less than we once thought, to the point where they may not have any significant benefit at all, but we certainly have evidence that shows that they can cause harm with neck injuries and potentially occlude patients' airways. So look more into this with the focused spinal trauma lecture, but for the purposes of assessment, this is the type of assessment we want to do to help us make those decisions about what further spinal immobilization is needed. And the problem list and the plan. So what is going on with your patient? Make a list. You don't have to have fancy diagnoses. And what are you going to do about it, if anything? And culminate this and talk about it with your medical team, because the evacuation plan and the treatment plan really should involve the team leader. It's going to involve potentially folks with logistics and incident command, and certainly your medical person. Even though if you have a physician or paramedic or whoever it is that has the highest level of medical training, certainly should have the most input about the treatment plan for that particular patient. However, this really needs to be coordinated with the team leader and the field leader or incident commander to look at the overall context and safety for the mission for all the rescuers involved. So whether or not somebody would have the most benefit from an air rescue certainly can be the recommendation of the medical person, but whether or not an air rescue is executed really needs to be in the context of the safety of the airlift crew and the rest of the team members involved. interventions and treatment. So we really want to focus on stabilizing care. What is it we can do for those A, B, C, D, E's? What can we do to stabilize life threats? The next most important thing is comfort care. What is it we can do to make the patient more comfortable? What is it that we can do to splint things, to provide either heat or cold? Pain or nausea medication if available or appropriate. Padding the litter in a way. And then toileting. Making sure these people are peeing and pooping, and then making a plan ahead of time for when toileting needs come up. Especially for prolonged carryouts, it is really important that we tell people that it's a good thing if they're peeing or pooping. We want to know about it. It's nothing to be ashamed or embarrassed about. That we have a plan in place, and we have a plan to care for them. This can be the use of an adult diaper. It can be the use of a condom catheter. It can be tilting the litter to allow them to urinate. If they don't have a spinal injury, it can be opening the litter and allowing them to come out and relieve themselves before repositioning them back in the litter. It can be improvising an adult diaper with the patient's fleece clothing and a garbage bag. There's lots of things that you can do, but make sure that you train talking about this and make sure that you have a toileting plan in place. And it's very important to make sure that your patient knows that this is expected, it's normal, it's not gross, or else what they'll do is they'll hold it and they'll keep it inside and not tell you for fear of being perceived as being gross or bothersome or burdensome, and it can really lead to a psychosocial and medical decline in your patient's well-being, and it's important to stay on top of that. The same is true with hydration and nutrition. There are very few exceptions in which we do not want to offer our patient food and fluid by mouth. Especially if your patient is going to be out in the wilderness for more than 2 hours, if it's not an immediate pick off or an easy extrication, we need to start thinking about keeping our patients hydrated and making sure that they have nutrition. This will help not only with their psychological care, it'll help prevent them from having instability in their blood pressure and getting dehydrated, and it will also help their body keep itself warm through shivering and keep them healing as well. And then very important, if not the most important, is psychological care. For many of these patients, they've lost all sense of control. They're embarrassed. They're scared. They may have felt like they were going to die. And now they're in a very unfamiliar environment and feeling very vulnerable. So it's important to have a single point of contact person, preferably the medical person, who's explaining everything in a detailed way. You need to create a space and environment where patients feel empowered to ask questions and share discomfort that they're having and feel like they're not being burdensome when voicing those concerns. And it's important to give them control where possible. Making sure they have use of their hands is important if that's appropriate. Giving them choices where appropriate. And checking in with them frequently to make sure that they're as comfortable as can be and they understand what's happening to them, and they know what the plan of care is. And then ongoing monitoring, especially for either medically sick or traumatically injured patients, or if carryout is going to be more than an hour or two, it's important that we continue to reassess their pain management and their comfort. People shift in their litters, splints shift and change. So how can you position the patient and the splinting to make it optimal for comfort and for stability, keeping them informed and update frequently about what's going on, making sure that we're readjusting toilet needs frequently, and then making sure that they're either not too hot or too cold and they're not becoming increasingly hypothermic. The default is patients are going to feel that everyone's in a hurry and tired or upset or frustrated. They're going to feel like they're in the way. They already feel like they've been overly burdensome, and they're not going to naturally feel empowered to raise these concerns and ask for help and to let you know when they're uncomfortable. So it's very important that you make them feel comfortable doing so, and that is the normal expectation is for them to share that with you. You're going to want to potentially reassess their vital signs, particularly their mental status. And this can be an ongoing thing done by the patient advocate or the medical person. And it might be appropriate to stop and reassess, especially in somebody that had a significant injury, significant illness, or abnormal vital signs to begin with, to recheck their vital signs, their heart rate, blood pressure, respiratory rate, oxygen saturation in their skin. And how frequently you do this is going to be largely dictated by how unstable they are, how long the carryout is, and how sick or traumatically injured the patient is. And then nutrition, making sure that we're offering oral fluids and calories to keep them heated as tolerated. If your patient is unconscious, unresponsive, or obtunded and significantly confused, and you're worried about their ability to take food or fluids, don't force it on them. This is not something that you want to force. Or if your patient is persistently vomiting and not tolerating food and fluids, then don't force it. But in general, if you have a patient who's awake and alert, and they're not vomiting, and they can swallow on their own without any coughing or without any problems, then generally the benefits will outweigh the risks in most circumstances about keeping these patients both hydrated and fed. So the key points are, the most important thing is to approach this with the lens of looking at the overall safety of the mission and your rescuers, and assessing the scene size up. Your priority when you approach the patient after introducing yourself and getting permission to treat the patient is to stabilize the life threats. So check your A, B, C, D, E. Make sure you expose everything down to skin. Understand where your significant injuries are. The next step is either your relevant history or your head-to-toe examination is appropriate, and that's going to be dictated by whether this is a traumatic injury or if this is a medical problem. Ultimately, you're going to need to get all this information. The concept is to get the most important information first, so you can start to formulate a picture in your head about what's going on with your patient and how sick they are. Make sure that you address and focus on comfort. Make sure that you have a plan for toileting, and make sure you do it prior to patient packaging and offer it often. And then make sure that you're offering hydration and nutrition as long as you have an awake and alert patient who is not coughing and not vomiting. So hopefully this is helpful and puts things kind of in a context for a generalized approach as we start to talk about more specific medical conditions.